Good evening. Good evening, Jeetu Meena. Good evening, Dr. Dreamer. Good evening, all of you. Good to meet you all. I know there is so much going on in your mind amidst the confusion that is created by the postponement. Yeah, good evening, Animesh. Hi, all of you. Good evening, Rubina, Arpi. Hi, Harsha. Yes. So I know there is so much going on in your minds amidst the confusion that is created by postponement. And if you ask me, I would say be on the top of your game. Yeah. So postponement or no postponement, let's always be on the top of our game. Let's try to not lose the momentum with which you have been preparing so far. Let's try to revise as much as possible in the time that is provided to you. Yeah, let's assume that the exam is not being postponed. Let's do our best. Okay. Yeah, it's high yield marathon session. Yes, high yield MCQs. Yes, Jeetu Meena. Voice is too low. Am I audible? Am I audible, all of you? Is it fine now? Audible? Okay. Fine. So in this session, I will try to be loud. I think it should be fine now, right? It should be fine now. Yes. So today I have chosen few high yield case-based and image-based MCQs because these days it's all about integrated biochemistry, right? It's clinical biochemistry. So I'll help you understand as much clinical biochemistry as possible in today's session. Okay. So let's start with the first session. So this is the first question. Long time for biochem revision. I'm happy that I'm able to help you now. Hi Hippo. Hi. Good to meet you now. Yes. The session will be from 1 to 1.5 hours. 1 second. Everybody says, yeah, this is 1 to 1.5 hour session. Okay, yeah. So let's start discussing this MCQ. I hope you must have all seen this MCQ on the Instagram account, right? PrepLadder Med Instagram account. And I saw that there were like 92 responses, and all of them had answered it as phenylketonuria. At least here I see some answers like tyrosinemia given by pilot. Some of you are answering it as phenylketonuria. Deepthi Narayan has answered it as methionine malabsorption. Very good, Deepthi. Yes, what is the right answer? The right answer is methionine malabsorption. Yeah, I gave you this MCQ purposely because I know that you must not have heard of methionine malabsorption. I want you to know that both methionine malabsorption and phenylketonuria closely resemble each other. Okay, so there is some sound connectivity from your device. It's not clear enough. Device, it's not clear enough. I am able to hear myself on my mobile. I think you have to adjust your system, Yanam Deepak. Yeah? Little echo. No problem. I'm going to tell you about all of this. You don't have to cry. Okay? Yes. So what made you is increase or methionine malabsorption? Excellent. Yes. So I'm going to tell you now about this MCQ. What made you answer it as phenylketonuria? Of course, phenylketonuria will present with mental retardation. The patient will definitely present with hypopigmentation in phenylketonuria. And phenylketonuria also presents with the characteristic odor, right? What is the characteristic odor that phenylketonuria presents with? It presents with mousy odor. Yes, you can get the PDF, Sunil Kumar. I'll share it. It presents with mousy odor. So these three features definitely resemble, and yes, ferric chloride test will be positive even in phenylketonuria. But my question to you all is, does phenylketonuria present with diarrhea? Have you ever read in any of the textbooks that phenylketonuria presents with recurrent diarrhea? No. Similarly, do you think in phenylketonuria there will be methionine load test that is done to detect the presence of excess of alpha hydroxybutyrate? No, right? That is why my request to all of you is, whenever there is a case-based MCQ, please read the entire history. Okay, and whenever you see a clue like methionine load test, yeah, that should tell you that it's got nothing to do with phenylketonuria, because phenylketonuria is caused by the defect of phenylalanine metabolism. So what is the right answer here? The right answer here is methionine malabsorption. Okay, so I'm going to tell you all about methionine malabsorption, and then I will also help you differentiate methionine malabsorption from phenylketonuria. As the name indicates, in the case of methionine malabsorption, when there is malabsorption of methionine, methionine stays back in the intestine and methionine attracts water, and that causes diarrhea. So tell me, what will be the predominant feature of most of the malabsorption syndromes? They all present with diarrhea. Now, unabsorbed methionine reaches colon, and in colon, microorganisms act on methionine, will convert this methionine into alpha hydroxybutyrate. Does that ring a bell? Where have you come across something similar to alpha hydroxybutyrate? Anybody? Where have you come across something similar to alpha hydroxybutyrate? Have you heard of something called as beta hydroxybutyrate? What is beta hydroxybutyrate? It is a ketone body. So similar to that, microorganisms form alpha hydroxybutyrate in the colon from methionine. And this alpha hydroxybutyrate gets, very good all of you, excellent, yes. This gets absorbed into the circulation, and when there is excess alpha hydroxybutyrate in the circulation, this substance will compete with other neutral amino acids to cross the blood-brain barrier. So brain does not have adequate neutral amino acids which are necessary for brain development, and that is why the patient will present with mental retardation. So not only diarrhea, there is also mental retardation component because of alpha hydroxybutyrate getting into circulation, competing with neutral amino acids to cross the blood-brain barrier. This alpha hydroxybutyrate will get excreted in the sweat. Okay, and this has got a characteristic odor, and that odor is beer odor. So if you see a term, beer odor of a baby, beer baby syndrome, otherwise called as Oast house odor. Okay, Oast house odor or dried hops flour odor. Okay, dried hops flour odor. All these mean the same. So what is the odor that you observe in methionine malabsorption? Is beer baby syndrome. Good, Nalini. It presents with dried hops flour odor or Oast house odor, otherwise called as beer baby syndrome. Okay, and if you're asking me what is an Oast house, this is how an Oast house would look. So these houses are present in Western countries wherein they dry hops flour to add flavor to beer. And that is why all these names, dried hops flour odor, Oast house odor or beer baby odor. Okay. And I want you to have this image in your mind to have a visual memory of blue sky and white clouds. What will you use to remember? Blue sky and white clouds. A child of methionine malabsorption will present with blue eyes and white skin. In the sense they present with hypopigmentation. So why is hypopigmentation a feature? Why is hypopigmentation a feature of methionine malabsorption? It is because methionine is necessary as an inducer for tyrosinase. What is the role of tyrosinase? Tyrosinase is necessary to convert tyrosin to melanin. Okay, tyrosinase converts tyrosin to melanin, and that is necessary. Tyrosinase needs methionine to get activated. So in methionine malabsorption, there is hypopigmentation. So the child will present with white skin and blue eyes. Okay, and when alpha hydroxybutyrate gets excreted in urine, urine has got now a ketone, and any ketone when it is present in urine will answer ferric chloride test. So I want you all to remember that ferric chloride test is not a specific test done only for phenylketonuria. Ferric chloride test will be answered whenever any ketone body is present in urine. One of the conditions is phenylketonuria, another condition is diabetic ketoacidosis or starvation ketosis or methionine malabsorption syndrome. Okay, so ferric chloride test, and what did I tell you? Hypopigmentation is also a feature of methionine malabsorption. So have you all understood about methionine malabsorption? The moment you see methionine malabsorption, you should remember methionine stays back in the intestine, attracts water, causes diarrhea. Colonic microorganisms convert it into alpha hydroxybutyrate, which gets absorbed into the circulation, goes and competes with neutral amino acids to cross the blood-brain barrier. That causes mental retardation. It gets excreted in sweat, and that is why Oast house odor or beer baby odor, otherwise called as dried hops flour odor. And imagine or visualize the host house with blue sky and white clouds. They also present with hypopigmentation. Urine will answer ferric chloride test. And out of all these features, can you tell me what are the features which resemble phenylketonuria? All these will resemble phenylketonuria. Yes or no? All those which I've highlighted in orange color, these are common between phenylketonuria and methionine malabsorption. So how will you differentiate these two clinical conditions? The first feature is methionine malabsorption will present with recurrent diarrhea. Phenylketonuria does not. And the second feature is hypopigmentation will be more pronounced in methionine malabsorption. Do you all understand this? Hypopigmentation is more pronounced in methionine malabsorption. That is, you find hypopigmentation even in phenylketonuria. Okay, that's why I said blue sky and white clouds. Okay. And the third way by which you can differentiate the two conditions is methionine load test. After you give a load of methionine, we estimate alpha hydroxybutyrate. If the concentration is elevated, that is diagnostic of this condition. These days, we don't do any of these load tests. Have you seen anybody doing methionine load test to a newborn? We don't do this because now we have a sophisticated investigation which is HPLC with tandem mass spectrometry. What is it? Yes, mousy odor. Very good. PK, I can see that you're here from your request to highlight. I will do it, PK, for sure. Okay. So what was I telling you? What is that we do these days? These days we do HPLC with tandem mass spectrometry for making a diagnosis of any inborn error of amino acid metabolism. So please get this registered in your mind. What is it? High performance liquid chromatography with tandem mass spectrometry is going to give you the concentration of almost like 300 parameters. So by looking at the values of all these parameters, you'll be able to make a diagnosis of any amino acid metabolism disorder. So these days we don't do these load tests, but if it's given in the question, please remember that is methionine malabsorption syndrome. Got it? Yes. So tell me what is the right answer here? Because there is hypopigmentation, let me highlight all the features. Because there is hypopigmentation and the characteristic odor, and because ferric chloride test is positive, there is mental retardation. So all these features are common to which disorder? Common to phenylketonuria as well as methionine malabsorption syndrome. So how do you differentiate these two conditions? You can differentiate these two conditions by looking at methionine load test showing an increase in alpha hydroxybutyrate and by the presence of recurrent diarrhea. Okay, good. I'm happy that all of you are answering. But before we end the discussion on this MCQ, can we discuss about characteristic urine odor and diagnosis? Can we do that? Yeah, what is the urine odor and what will be the diagnosis? Because it's being frequently asked, right? So let's start with the first one. As you all have been answering, mousy odor is a feature of what? Good, Dr. Sarika. Tell me. I will definitely tell you about all these odors. Tell me. Mousy odor is a feature of phenylketonuria. Okay. How do we memorize it? Have this image in your mind. Don't you know that mouse and keyboard go hand in hand, all of you? Yes, mouse and keyboard go hand in hand. So mousy odor is a feature of what? It's a feature of phenylketonuria. You never should get confused here. Okay. And the next odor is fruity odor. After mousy odor, it is fruity odor. Can you all answer? Fruity odor is a feature of diabetic ketoacidosis. After fruit, it is a vegetable. Which vegetable is it? Cabbage. Cabbage odor is a feature of type 1 tyrosinemia. Okay, cabbage odor is a feature of type 1 tyrosinemia. How to remember this? Have this image in your mind. Do you see that here? Tire has been repurposed to grow cabbage. Yeah, tire has been repurposed to grow cabbage. So cabbage odor is a feature of what? Type 1 tyrosinemia. Okay. After cabbage odor, it is boiled cabbage odor. What is next? It is boiled cabbage odor. We all know that cabbage odor by itself is not that great, right? Now, boiled cabbage odor is even more difficult to handle. Yeah, it is too much to handle. Too much is hyper. It is hypermethionemia. Okay, it is hypermethionemia. Boiled cabbage odor is a feature of hypermethionemia. After hypermethionemia, let's have this methionine malabsorption syndrome. Can you all answer this? Methionine malabsorption syndrome, what is the odor that you observe? It is either Osthaus odor or dried hops odor or beer baby odor. Okay, so that's about methionine malabsorption. And as I told you, this is Osthaus. You're going to use this picture to remember what? Blue sky and white clouds. A person presents with hypopigmentation with blue eyes and white skin. Okay, and after this is Osthaus. Let's remember house with a swimming pool. Okay, so swimming pool odor is a feature of Hawkinsinuria. Swimming pool odor is a feature of Hawkinsinuria. So how to remember it? Very good, Dr. Sarika. Do you see this image? And in this image, do you see that a hawk is flying above the swimming pool? Right? Hawk is flying above the swimming pool. So swimming pool odor is a feature of Hawkinsinuria. Please don't forget this. And Hawkinsinuria is characterized by, or it is caused by, a gain of function mutation of para-hydroxyphenylpyruvate dioxygenase. Okay, swimming pool odor is caused by a gain of function mutation of para-hydroxyphenylpyruvate dioxygenase, and that is characterized by swimming pool odor. Okay, and after swimming pool, sweaty feet odor. The next one is sweaty feet odor is a feature of isovaleric acidemia. Okay, it is isovaleric acidemia. How to remember this? Again, an image. Do you see feet kept on the ice? Do you see feet kept on the ice? So sweaty feet odor is a feature of isovaleric acidemia. And the next one I know most of you know, right? What is that you know? Yeah, burnt sugar odor. What is burnt sugar odor or maple syrup odor? Burnt sugar odor or maple syrup odor is a feature of branch chain keto acid dehydrogenase deficiency. We know that, right? Already maple syrup urine disease is caused by the defect of branch chain keto acid dehydrogenase enzyme. And apart from this, I want you to remember about the fish odor. Yeah, fish odor syndrome is for some reason it's a favorite of AIMS. Okay, so fish odor syndrome is caused by trimethylamminuria. It is caused by trimethylamminuria. And the last one is tomcat urine disease. Tomcat urine disease is caused by multiple carboxylase deficiency. To remember that in cat you see Ca and it is caused by multiple carboxylase deficiency. Okay, so that's all about urine odor and diagnosis. So where did we start? We started with mousy odor. Mouse and keyboard go hand in hand. Key is ketonuria. Mousy odor is a feature of phenylketonuria. Fruity odor is a feature of diabetic ketoacidosis. After fruit, remember a vegetable. Cabbage odor is a feature of cabbage grown on a tire, right? Type 1 tyrosinemia. Then boiled cabbage odor is too much to handle, hypermethionemia. Methionine malabsorption syndrome is characterized by Osthaus odor or beer odor or dried hops flour odor. And then this is house, then a pool. Swimming pool odor is a feature of Hawkinsinuria. Sweaty feet odor, feet kept on the ice, isovaleric acidemia. Burnt sugar odor, maple syrup urine disease caused by the defect of branch chain keto acid dehydrogenase enzyme. And then fishy odor, fish odor syndrome is caused by trimethylamminuria. And the last one is tomcat urine disease is caused by multiple carboxylase deficiency. Okay, so helpful, right? I'm happy that you're all enjoying it. So that's all about the first question. Yeah, using that one question, we have discussed so many facts and concepts. Now this is the next question. Thanks, Dr. Sarika. So this is the next question. In blue and white technique, white colonies represent what? So this is an image-based question. This was asked twice in AIMS, not after it became INI-CET. Before that in AIMS, they had asked you this question twice. So what do you think is the right answer? Anybody? PDF I will share. Definitely I will share. Some of you are answering it as D. Successful alpha complementation and presence of E. coli colonies with native vector. Some of you are answering it as C. Failure of alpha complementation with native vector. Some of you have answered it as B. Okay. Deepthi again. Very good, Deepthi. Deepthi is rocking it. What is the right answer here? The right answer is it's failure of alpha complementation and presence of E. coli colonies with recombinant vector. Yeah, so there was one question on alpha complementation without an image, and there was an image based question based on the same concept. Okay, so let's try to understand what is blue and white technique. For this, I'm going to start building from the basics. Okay, let's start understanding what is recombinant DNA technology. Then you will understand what is the significance of lac operon, and then you will understand about blue and white technique. Okay, so first about recombinant DNA technology. Who wants to tell me what is the significance of recombinant DNA technology? What is the main purpose of it? Yeah, it helps in genetic engineering. Suppose you are trying to produce insulin on a large scale. What will you need first? You will first need insulin gene in multiple copies. Only then you will get insulin mRNAs in multiple copies. Finally, you will get to have insulin protein. So the first step is you want to produce insulin gene in multiple copies, for which you are going to take a human chromosome fragment which has got the insulin gene. So step number 1 in recombinant DNA technologies, you take a fragment of human chromosome which has got the gene of interest. And then you're going to attach this fragment with a vehicle. Why am I calling it as a vehicle? Because that vehicle is going to carry this fragment and get into E. coli. And within E. coli, it is going to be amplified. So what do you do next? You take a vehicle or a vector. But for you to introduce the fragment with gene of interest, for you to introduce the fragment with gene of interest into the vector, you should cut the vector. And how will you cut the vector? Using restriction endonuclease, you have cut the vector. And then you attach the fragment with gene of interest. Steps also asked in INI-CET, SPK. You're right. Excellent, yes. So now you attach the fragment with gene of interest to the vehicle to form something called as recombinant vector. So now do you all understand why it's called as recombinant DNA technology? Because you are linking two unrelated genomes. First, you are attaching a human chromosome fragment, eukaryotic gene fragment is attached to a prokaryotic vector. So the product is called as a recombinant vector. Formation of recombinant vector is difficult. And even after you form a recombinant vector, introducing this recombinant vector into E. coli is even more difficult. Because you are trying to introduce such a larger particle across cell wall. You know, E. coli is a prokaryote with cell wall. So introducing such a larger particle across a cell wall is not going to be that easy. So what we do is, using high electric currents, we introduce pores onto the cell wall. Through those pores, the recombinant vector will be taken up. Okay, and after it has taken up the recombinant vector, there should be a way of you identifying those E. coli colonies which have taken up the recombinant vector, and you should allow only those colonies to grow. Otherwise, what will happen? E. coli colonies without the vector will overgrow this. Though we speak so high of recombinant DNA technology, do you all know that recombinant DNA technology is carried out on a simple culture plate? Yeah, you must have all seen culture plates, right? Only the recombinant DNA technology is done. So there will be always competition among colonies. So after you make an attempt to introduce recombinant vector into E. coli, you should find a way of identifying those E. coli colonies which have taken up the recombinant vector. Okay, and for that we use marker genes. Are these important topics or rare topics? These are not rare. Shankar Namala. Okay, that's a good question to ask. So whenever I teach something which is conceptually, students get into that mode of doubt. Yeah, they start thinking, do I have to really know it? But after the question is asked, they will be after the teacher asking to explain it. So this is not a rare question. Yeah, will you all agree with me if I say, that there is a rapid progression in molecular diagnostics? Yes, right? Molecular biology, molecular diagnostics, cytogenetics, there is a rapid acceleration in the progress. And these days there are so many questions which are asked, and take it from me, this is not a new question that I framed it all by myself. This is a PYQ. Okay, so don't doubt about the importance of all the facts and concepts that I'm discussing here. I will not waste your time. Okay, I will not discuss just rare MCQs. Okay, so that is the significance of marker genes. Now, the most commonly used marker gene in artificial vectors, yeah, the most commonly used marker gene is beta-galactosidase gene. And I hope you all remember this lac operon. Don't you all remember? Yeah, lac operon is often asked in AIMS, often asked in INI-CET, often asked in NEET PG. So, beta-galactosidase gene, a part of lac operon, is used as the marker gene for this purpose. So, how do we do this? For this, we use E. coli. Okay, the moment you have decided to use this as a marker gene, what we will do is we will not randomly take any E. coli and subject it to recombinant DNA technology. We use a specific E. coli which has undergone mutation in the beta-galactosidase gene, so that it can produce only the omega subunit of the enzyme. So what have you used? You have used a mutant E. coli with a mutant beta-galactosidase gene which produces only the which fragment? Only the omega subunit. But what is lacking here? The alpha subunit is lacking here. And you will choose the vector in such a way that the vector has got the gene which can produce the alpha subunit. Okay, the vector will have the alpha subunit coding region. So let me show you this. This you will be able to understand. So this is an E. coli which has taken up the vector. We tend to mutate in E. coli. Thank you, ma'am. Yeah. All expected areas, yes. We tend to mutate in E. coli in the sense we don't take it and mutate it. We choose E. coli colonies which have already undergone mutation. We allow them to propagate. Do you understand that? Yes. So this is the E. coli, and this E. coli has got, this is the E. coli genome. Okay, and this E. coli genome has got mutated beta-galactosidase, which will produce which fragment? This will produce just the omega fragment. And this is the vector. This vector will have the alpha subunit. So if E. coli has taken up the vector, that is alpha complementation. Do you see that? Yeah, in this case, both omega subunit and alpha subunit are present. This is called as alpha complementation. Once alpha complementation is done, the E. coli will be able to produce active beta-galactosidase enzyme. Now, what you do is, if this is the culture plate, to this culture plate, we add the substrate for beta-galactosidase. And this was asked once. The substrate for beta-galactosidase is X-gal. The substrate is shortly called as X-gal. It is otherwise called as 5-bromo-4-chloro-3-indoxyl galactoside. Okay, so what is added? It is X-gal, which is otherwise called as 5-bromo-4-chloro-3-indoxyl galactoside. So if there is active beta-galactosidase, it goes and cleaves this X-gal and it provides blue color. So if you see blue color colony, what does it mean? If you see a blue color colony, it means there is alpha complementation. If there is alpha complementation, it means the E. coli has taken up the vector. It is just the vector. So the story is not yet over. Okay. Within the alpha subunit is the restriction site. Within the alpha subunit is the restriction site. So for you to introduce the fragment with gene of interest, you would have cut the alpha subunit and then you would have introduced the gene of interest. Which means if E. coli has got recombinant vector, it will not have the alpha subunit. Do you all understand this? If E. coli has got the recombinant vector, it will not have the alpha subunit. No alpha complementation. Without alpha complementation, what will happen? There will be white color colonies. Have you all understood this? There will be white color colonies. So let me tell you this in short. So finally, this is how the colony plate would look. Do you see blue color spots and white color spots? Yeah. So what does it mean if there is a blue color spot? No, that is beta-glucosidase, Abhay. Beta-glucosidase is present in eukaryotes, in human being. Here it is beta-galactosidase, which is an enzyme of prokaryotes. It's a part of lac operon in E. coli. That is beta-galactosidase is beta-glucosidase. Got it? Yeah. So what does it mean when you see blue color colony? If you see blue color colony, it means successful alpha complementation. If there is successful alpha complementation, it means the alpha subunit has not been cut. If it is not cut, it means there is no recombinant vector. It means there is no recombinant vector. What does it mean when you see a white color colony? It means there is failure of alpha complementation. What does it mean if there is failure of alpha complementation? It means what is cut? The alpha subunit is cut. After that, what is implied? You have introduced the gene of interest. So that will have the recombinant vector. Got it? Yeah, so this is about blue and white technique. So to summarize for all of you, yeah, for the benefit of all of you, I want you to remember that recombinant DNA technology most commonly uses beta-galactosidase as a marker gene. And for this purpose, what do you use? You use a mutant E. coli, wherein what is mutated? The beta-galactosidase gene is mutated. It will provide only omega subunit. But to compensate for it, you choose the vector in such a way that it has got the alpha subunit coding region. So if E. coli takes up the vector, just the vector, there is alpha complementation and you see a blue color colony. Whereas if there is recombinant vector, the alpha subunit is cut. So there is no alpha complementation, you will see a white color colony. They might ask you what is the substrate that is used in blue and white technique. You should know it is X-gal. It is otherwise called as 5-bromo-4-chloro-3-indoxyl galactoside. Okay? Yes. So what is the right answer, all of you? In blue and white technique, white colonies represent what? Can you tell me the answer now? If there is white colony, it means there is failure of alpha complementation, but that's a good sign. Failure of alpha complementation means there is E. coli colony with recombinant vector. Good. Yes. Yes, PK. White color colony means it is successful. Okay. So this, I am hoping that most of you must have seen this MCQ. Yes or no? Following CRISPR mediated gene next, which of the following can result in gene knock-in? Have you seen this MCQ? This is a PYQ. So what is the right answer? We want white colonies. You are right. Non-homologous end joining. Most of you are answering it as non-homologous end joining. All of you are with the same answer. Dr. Dreamer has answered it as homologous DNA repair. Some of you have answered it as Q helicase mediated repair. So what is the right answer? The right answer is homologous DNA repair. So Dr. Dreamer is right. Jitu Meena is also right. Sashikala is also right. Very good. So the answer is homologous DNA repair. Okay. So I'm going to use this MCQ to help you understand what is all about CRISPR. Okay. So because the last Nobel Prize was given for identifying, for using CRISPR for gene editing, let's try to understand what happens here. Okay. And before we start discussing about CRISPR, let me define all these terms, because sometimes they ask you about gene knockdown, sometimes they ask you about gene knockout, sometimes they ask you about gene knock-in. Let's try to understand all these definitions first. So first about gene knockdown. Gene knockdown means you are down regulating a gene expression. Isn't that implied? In gene knockdown, you are down regulating the gene expression. First tell me, what is gene expression? Gene expression is nothing but you take a gene. Okay, in gene expression, this was also taught by Nikita ma'am, and it's homologous DNA repair. Yes, ma'am said it. Yeah, she's always right. She has told this also right. So what do you mean by gene expression? Gene expression is gene giving rise to mRNAs and mRNAs giving rise to protein. Yeah, this is what we call as gene expression. So what do you mean by down regulating gene expression? If there is something which can decrease the number of times of expression of a gene, if there is something which can decrease the number of protein molecules that you get out of the gene, that is called as down regulating gene expression. Which means in this case, you are not editing the gene. The gene sequence will remain the same. Do you understand this? The gene sequence remains the same. After that, you are regulating the gene expression. Okay, so that's about gene knockdown. Now, what is gene knockout? Gene knockout is, here you are going to remove the defective gene. It's a process where you remove the defective gene. It uses both homologous and non-homologous. No, I'm going to tell you about it, Dr. Kiffin. If you can hold on for some time, in another 10 minutes, you'll understand what is non-homologous end joining and what is homologous DNA repair. Yeah, after that, you will have no doubt about it. Okay. So what is gene knockout? It is just removal of the defective gene. What is gene knock-in? You are replacing the defective gene with a normal gene. So don't you understand that in the case of gene knockout and gene knock-in, you are changing the gene sequence. You are either removing the defective gene or you are replacing the defective gene with a normal gene. So here we are editing the gene. So gene knockout and gene knock-in is editing gene, whereas gene knockdown is just down-regulating gene expression, and that is done by interference. Do you all understand this? Please remember, have you learnt about siRNA? Yeah, small interference RNAs or miRNAs. They mediate interference phenomenon. How do we say they mediate interference phenomenon? Because they interfere with the gene expression. Do you understand this? They interfere with the gene expression. So today, please memorize it. siRNA and miRNA. What do they bring about? They bring about gene knockdown. They down-regulate gene expression. Whereas gene knockout and gene knock-in is gene editing. How do you bring about gene editing? One of the ways by which you can edit gene is CRISPR. Okay, so what do CRISPR-Cas enzyme system do? For you to answer this question, you should know what are the components of CRISPR-Cas enzyme system. And as the name indicates, this system has got a Cas enzyme. What is a Cas enzyme? It's an endonuclease. What will an endonuclease do? It will go and make a nick on a double-stranded DNA. Endonuclease will go and make a double-stranded nick. It causes double-stranded DNA break. Does that mean this Cas enzyme randomly goes and cuts anywhere it wants? No. Cas enzyme is very specific. It goes and cuts only at those sites which are complementary to its guide RNA. So tell me, what are the two components of CRISPR-Cas enzyme system? One is a Cas endonuclease, which brings about a double-stranded DNA break, and that is guided by guide RNA. Cas enzyme goes and cuts only at sites which are complementary to guide RNAs. And this CRISPR-Cas enzyme system is used as immunological memory by bacteria. Yeah, it is not present in human being. You all know that, right? It's not present in human being. CRISPR-Cas enzyme system is used as a form of immunological memory by bacteria to protect themselves against bacteriophages. So this has been existing, this has been identified long back. So what did Emmanuel Charpentier do? I hope you all know that Emmanuel Charpentier is the one who received the Nobel Prize for this. So what did Emmanuel Charpentier do? Because she understood this Cas enzyme makes specific nicks, she thought, why not we use for gene editing? Okay, so what happens after it causes a double-stranded DNA break? Ma'am, is gene knockout always followed by gene knock-in? No, Hemant. Wait for 2 more minutes, okay? 2 more minutes, you will understand everything. Okay, so what does CRISPR-Cas enzyme system do? CRISPR-Cas enzyme system causes double-stranded DNA break. And whenever in your genome there is a double-stranded DNA break, be it caused by CRISPR-Cas enzyme system or it can be caused by ionizing radiation. Why are you all worried about gamma rays? Why are you all worried about all these ionizing radiations? Because they can cause double-stranded DNA break. So whenever there is double-stranded DNA break in our genome, we repair it by one of the two mechanisms. One mechanism is non-homologous end joining. The other one is homologous DNA repair. So what is non-homologous end joining? This is brought about by Q helicase, Ku helicase. It is brought about by Ku helicase, and this is a dimer. Suppose this represents a double-stranded DNA break that is caused by CRISPR-Cas enzyme system. Q helicase is a dimer, and each of the two units will go and bind to both the ends like this. Can you see that? They go and bind to both the ends like this. After they go and bind, what do you think they will do? Helicase will cause unwinding. So following unwinding, the two ends will look like this. And not only unwinding, Q helicase also mediates approximation of both the ends. So both the ends approximate with each other until they find base pairing somewhere here. And once base pairing is done, the excess strand will be removed. And ligase will unite the ends. Yeah, excess strand is removed and ligase will unite the ends. So is that clear? What is non-homologous end joining? What happens in non-homologous end joining? It is done by Q helicase, which goes and binds to both the ends. It causes unwinding and approximation of both the ends. The approximation will continue until they find base pairing. Then excess strands get removed and ligase will unite the ends. So do you understand that in non-homologous end joining there is loss of gene sequences? All of you? Do you all see that there is loss of gene sequences? What do you think that will result in? Whenever gene sequences are removed, that is called as gene knockout. All that you can bring about is you can just remove the defective gene. Okay, so non-homologous end joining results in gene knockout. So what is homologous DNA repair? I hope it's clear to all of you. If it's clear, can I see a thumbs up, please? Now this is about homologous DNA repair. So what happens in homologous DNA repair? This is brought about when there is a homologous DNA sequence which tells the repair system this is how it has to be repaired. For example, if the double-stranded DNA break, thanks all of you, thank you. Suppose, excellent. Suppose this double-stranded DNA break is brought about in chromosome 16. What will be homologous sequence for chromosome 16? The other copy of chromosome 16. So if homologous DNA sequence comes nearby, so the red color chromosome has undergone double-stranded DNA break. The other chromosome is acting as a homologous DNA sequence. So when homologous sequences come close to each other, first DNA polymerase. Okay, these DNA polymerases have exonuclease activity. Using that exonuclease activity, they remove a part of the top strand. Okay, so that creates an overhanging edge. Can you see that here? Jai Kachatya. Why are you crying? Can I know? So can you see that there is an overhanging edge? RNA editing, then answer must be Abhay, no. If it's RNA editing, yeah, RNA editing is a normal phenomenon. RNA editing will result in normal gene synthesis. ApoB48 formation is an example of RNA editing. That is totally different. What I told you is RNA interference. Okay, RNA interference is gene knockdown. Okay, RNA interference is gene knockdown. So after this question, I will tell you, this is not RNA editing, Abhay. RNA editing is a normal phenomenon wherein we are able to produce multiple proteins from a single gene. ApoB48 formation is an example. RNA editing has got nothing to do with non-homologous. Is that clear, Abhay? Okay, so do you see an overhanging edge here? So this overhanging edge, no, homologous DNA repair can happen anywhere. What we are discussing now is in human. We are discussing now about human DNA repair, Dr. Dark Knight. Are you interested in yeast repair or human repair? Human repair, right? So yeast can also do this, but we are talking about how human DNA undergoes repair. Okay. So what was I telling you? So you see, what is that you see here? You see an overhanging edge. So this overhanging edge will have an ability to invade the strand. Can you see that happening? It has invaded the strand. And after invasion, this bottom strand will act as a template. And based on this bottom strand, the repair is done. The normal sequence is substituted. Okay. And once the filling is done, the other end of the strand will also invade and ligase will unite the ends. So what do you see happening here? If you're providing a homologous DNA sequence like this, you're not removing any sequence, you're substituting the gap with normal sequences. Do you understand this? You're substituting the gap with the normal sequence. So what does it result in? You're replacing the defective gene with a normal gene. You're telling the repair mechanism, this is what I want in my gene. So that results in gene knock-in. Have you all understood this? Yeah, that results in gene knock-in. So the summary. Yeah, I'm going to summarize it. Even if you have not understood so far, please note this down. Okay. So interference. Yeah, interference phenomenon. Yeah, otherwise mediated by small interference RNA or miRNA. What do these RNAs do? These miRNAs go and bind to fully formed mRNAs and they do not allow these mRNAs to be translated as proteins. They interfere with gene expression. That is why it's called as interference. They are down-regulating gene expression. So interference phenomenon will result in gene knockdown. Is that clear? Okay, that results in gene knockdown. And then CRISPR-Cas enzyme system. So if you look at CRISPR-Cas enzyme system, what do they bring about? They bring about double-stranded DNA break. And following double-stranded DNA break, there are two ways by which you can repair it. What are the two ways you can repair it? One way of repairing it is non-homologous end joining. The other one is homologous DNA repair. If it is non-homologous end joining, you're removing defective sequences. That is called as gene knockout. Okay, that is called as gene knockout. Homologous DNA repair, you are replacing the defective gene with a normal gene. That is why it is called as gene knock-in. Got it? Any doubts so far? So non-homologous enjoining is more common, that results in gene knockout, and homologous DNA repair will cause gene knock-in. Okay? Thank you, Devi. I'm happy that you're enjoying it. So what is the right answer here? Which of the following can result in gene knock-in? Tell me the answer. Very difficult to recall, seems like you're forgetting all. So Subhashini and anyone who's attending the session, I would strongly recommend that you start relishing the process of learning. Yeah, please start relishing the process of learning. Don't worry about the result. Yeah, that will happen all by itself. It's all about enjoying the process. Okay, so whenever you learn a new concept, even if it's a concept that you have already learned, yeah, if you've forgotten, please don't worry about it. Okay, this is my time. This is my time to revise. Let me revise wholeheartedly. Yeah, so that is how you should perceive it. Once you start enjoying, you will not feel the burden, and the retention will be better. Okay. Thanks, Aikawa. I hope I pronounced it right. Okay. So this is the next question. An ischemia forearm exercise. This is the first time you're understanding. Thank you. I'm happy that you're understanding. An ischemia forearm exercise test with a rubber ball is performed on a 22-year-old male patient who has a congenital deficit of muscle phosphorylase. So they've given you which enzyme is defective. It is muscle phosphorylase. So can you name the disorder, all of you? Muscle phosphorylase defect. Before ending today's session, can you please tell some words about anaplerotic reactions? I will do it, Gokul, definitely. Okay. So muscle phosphorylase defect is called as what? Yes, McArdle's disease. So this is a case of McArdle's disease. They have not asked you to make a diagnosis, but read it. When compared to a typical person doing the same test, what would this patient display? Yeah, what would this patient display? Increase in blood glucose, exercise endurance, increase in blood lactate in the blood drawn from the exercising forearm vein, relatively low blood lactate. Yes, glycogen storage disorder type 5. Very good. Sharmila has answered it as D. Dipti has answered it as D. I'm happy that many of you are answering it as D. Can you take one more class and cover a few more topics? Yes, tomorrow also we have a session. Tomorrow evening the same time, 7 o'clock. Yeah. So I see that some of you are answering it as increase in blood lactate, some of you are answering it as decrease in blood lactate. I majorly included this MCQ today to debunk the myth. Yeah, to debunk the myth that you have in your mind. Please remember, muscle cramps and lactate have no relevance. Do you all understand this? There is no link between muscle cramp and lactate. I know this is given in many NCRT books, but de-link it. Okay. So what is the reason for muscle cramp? Let me explain that to you in due course. But for now, what is about anaerobic exercises? Complete biochem lecture course. It will be available on the PrepLadder app from March. Okay. Yeah. So what was I asking you? I was asking you about anaerobic exercises, right? Yeah. So tell me, what are anaerobic exercises? No, what are isometric exercises? What do you mean by isometric exercises? It means the length of the muscle fiber should be maintained as a constant. So between two fixed points, when the muscle contracts, what will happen to the tone? In isometric exercises, suppose I'm asking you to squeeze a ball. I'm asking you to push against resistance. Yeah, if you're doing anything against resistance, like clenching your fist or pushing against resistance, the length of the muscle fiber should be maintained as a constant. And between two fixed points, when the muscle contracts, what will happen to the blood vessel which is entering into the muscle fiber? All blood vessels which are entering into these muscle fibers will get constricted. So will these muscle fibers get any fresh supply of oxygen? They will not get a fresh supply of oxygen. So will it be aerobic exercise or anaerobic exercise? It's going to be an anaerobic exercise. So have you understood that isometric exercises are anaerobic exercises because all blood vessels get constricted? And if it's an anaerobic exercise, can you tell me what will be the only fuel the muscle can use? Which is the only pathway in your body which can provide ATP even in the absence of oxygen? The only pathway is anaerobic glycolysis. So if a cell undergoes anaerobic metabolism, what is the only fuel the muscle can use? The muscle can use only glucose. Do you all understand this? Anaerobic glycolysis, yes. What will be the only fuel the muscle can use? It can use only glucose. And from where do you think a muscle can get its glucose? There are two places wherein muscle can get its glucose. One is from the blood vessel, right? One is through the blood vessel. The other one is from glycogen. And if it's isometric exercise, do you think the muscle will be able to extract glucose from the blood? For the same reason why it's not able to extract oxygen from the blood, it will not be able to extract glucose from the blood. So the muscle becomes dependent on only muscle glycogen. So whenever a person performs isometric exercise or anaerobic exercise, the muscle becomes dependent on its own glycogen. Do you understand this? Because what happens? Glycogenolysis happens. Glucose 1-phosphate is formed. Then glucose 1-phosphate gets into glycolysis, provides the necessary ATP. So this is the background of isometric or anaerobic exercise wherein muscle is dependent only on muscle glycogen. Now tell me about McArdle's disease, all of you. What is McArdle's disease? It is caused by the defect of muscle glycogen phosphorylase. When muscle glycogen phosphorylase is defective in a muscle, will the muscle be able to get glucose? No. When the muscle cannot get glucose, will there be anaerobic glycolysis? No. When there is no anaerobic glycolysis, will the muscle get ATP? No. Without ATP, there is muscle cramp. So what will be the principal presenting feature of McArdle's? How will you suspect McArdle's? When a patient complains of intolerance to anaerobic exercises. Whenever a patient complains of intolerance to anaerobic exercise, you should think of, okay, something related to glycogen or something related to anaerobic glycolysis is defective in this person. That is how you will have to suspect it. Okay, so how will the presentation be? In this case, when you ask the person to perform some anaerobic exercise, for the initial 10 to 15 minutes, the person will be able to exercise. And then the person will complain of painful muscle cramp. So what is the reason for painful muscle cramp? It is because of ATP depletion. Increase in muscle glycogen, but muscle cannot break it down. Yes, you're right. So what is the reason for painful muscle cramp? It is because of ATP depletion. Because please remember, not only for contraction, even for relaxation, your muscle needs ATP. Do you all know that? Not only for contraction, even for relaxation, your muscle needs ATP. Because if at all your muscle has to relax, the muscle should take back calcium into sarcoplasmic reticulum. How will a muscle be able to take back calcium into sarcoplasmic reticulum? That is with the help of calcium ATPase. That needs ATP. So not only for contraction, even for relaxation you need ATP. That is why whenever there is ATP depletion, there is painful muscle cramp. This is not due to lactate accumulation. Okay, and what do you think will happen in McArdle's to lactate level? In McArdle's, when glycogen phosphorylase is defective, when there is no glycogenolysis, when there is no glucose, no lactate production. There will be low lactate production in the exercising arm. Do you all understand this? There will be low lactate in the exercising arm, indicating that there is no glycogenolysis and no anaerobic glycolysis. And apart from this, I also want you to remember that there is something called a second wind phenomenon which exists in McArdle's disease. So what is second wind phenomenon? As I told you, when you ask the person to perform some isometric exercise like squeezing a ball or pushing against a resistance, for the initial few minutes the person will be able to perform, and then the person complains of painful muscle cramp because of ATP depletion. But if you ask the person to continue performing the exercise even after the person complains of painful muscle cramp, the person will say slowly it is getting relieved. Yeah, the person will say, yes, my pain is slowly getting relieved. That is called a second wind phenomenon. And the reason for the second wind phenomenon is metabolic switch. And what is a metabolic switch that happens here? muscle will switch over from anaerobic metabolism to aerobic metabolism momentarily. How is this possible? Because of momentary vasodilatation that happens. Yeah, so when there is painful muscle cramp, as an adaptive mechanism, there will be local vasodilatation that happens. Quickly the muscle will extract oxygen, the muscle will extract few fuels like glucose and fatty acid. Will use all these fuels, will use all this oxygen, will build ATP. Once ATP is built, the cramp will be relieved. So that is called as second wind phenomenon. Do you all understand this? So second wind phenomenon is nothing but this exists in a patient of McArdle's. So in a patient of McArdle's, when you ask the person to perform anaerobic exercise, for the initial few minutes the person exercises normally and then complains of painful muscle cramp, which is logical. Logic is no glycogenolysis, no ATP production. Okay, but if you ask the person to continue exercising even after the person complaining of muscle cramp, after some time the person will say that the pain is getting relieved. The reason for the relief from the pain is local vasodilatation. We call it as metabolic switch. What is metabolic switch? Muscle adapts and it switches over from anaerobic metabolism to aerobic metabolism. How is this mediated? Because of local vasodilatation, and any myoglobin that is present in the muscle will quickly diffuse oxygen. That will be used. So this is how the muscle will be able to perform exercise for some more time. That is called a second wind phenomenon. Is that clear? Great. So tell me, what is the right answer here? In a patient with McArdle's, will there be exercise endurance? There will be reduction in the exercise endurance. Will there be increase in blood glucose in the blood drawn from the exercising forearm vein? No. Will there be increase in blood lactate? No. What will you observe? There will be relatively decreased blood lactate. Okay. So this is the next question. I will be happy if you all try answering. Yeah, you don't have to be right. Already the answers are coming out. A young man sustained multiple injuries in a motor vehicle accident. He received blood transfusions and underwent surgery. 24 hours after admission, he passed 2,500 ml of urine. What is the right answer? Shruzana is answering it as renal acute kidney injury. Others, please. Same, renal acute kidney injury. Deepthi. All of you say it's okay. Mohan Raj says it's pre-renal acute kidney injury. Reformer. Okay. So there is a debate, right? There is a debate that is happening in your mind. Yeah, to choose between pre-renal and renal acute kidney injury. So this will happen when you try to choose the right answer just based on history. Okay, so I want you to look at all these values. Okay, so what is the history? The history is following a motorcycle accident. There is huge blood loss, and then that is followed by repeated blood transfusion, and then the person has passed lots of urine. Polyuria is observed, and then they've given you few values. And if you look at these values, what do you think about urea and creatinine values, all of you? Urea value, what is a normal urea concentration? Normal urea concentration is 15 to 40 milligram per deciliter. So here urea level is elevated. Creatinine normal value is 0.7 to 1.2 milligram per deciliter. That is also elevated. Yeah, I can see myoglobin induced acute kidney injury. Okay. I am happy that all of you are trying to answer. Good. But I will help you objectively to make a diagnosis. Okay. So what is happening here? There is an elevation of urea and creatinine, which means there is definitely kidney injury. And this is further substantiated by the fact that potassium value is elevated, right? What is a normal potassium? 3.5 to 4.5 milliequivalents per liter. In this case, potassium value is also elevated. So we know for sure there is acute kidney injury, but we do not know whether it's pre-renal acute kidney injury or renal form of acute kidney injury. So how are we going to differentiate it? Let me help you understand it. So whenever there is a huge blood loss, what will happen to afferent arteriolar pressure? Afferent arteriolar pressure decreases. Whenever there is a decrease in the afferent arteriolar pressure, glomerular filtration rate is reduced, right? And that causes acute kidney injury, and this is called as pre-renal acute kidney injury. Why am I calling it as pre-renal acute kidney injury? Because the kidneys are working properly. Before kidney, there is a circulatory deficit. Yeah, there is a circulatory deficit. That is why I call it as pre-renal acute kidney injury. But do you think following a blood loss, a patient can present only with pre-renal acute kidney injury? No. Because what happens when there is persistent for some time? When there is a circulatory or hypoperfusion of the kidney. Yeah, whenever there is hypoperfusion of the kidney, you know that the medulla gets affected, and when medulla gets affected, there will be acute tubular necrosis. So if it progresses to acute tubular necrosis, that is called as renal acute kidney injury. Yes or no? That is called as renal form of acute kidney injury. So please remember, based on history, do not go ahead with choosing pre-renal form of acute kidney injury. It can be pre-renal or renal. Okay, when there is acute tubular necrosis. So how will you differentiate these two conditions? First, tell me, why should you differentiate these two conditions? Because the prognosis is going to be different. Management is going to be different. If it's pre-renal form of acute kidney injury, to a larger extent it is reversible. Whereas if it's renal form of acute kidney injury, to a larger extent it is irreversible. So you'll have to find out whether it is pre-renal form or renal form. How are you going to find it? It is based on the fact that whenever there is a pre-renal form of acute kidney injury, whenever there is a reduction in the afferent arteriolar pressure, JG apparatus gets stimulated. And this JG apparatus releases renin. Renin produces angiotensin 2. That produces aldosterone. So if it is pre-renal form of acute kidney injury, that causes secondary hyperaldosteronism. Yes or no? Pre-renal form of acute kidney injury, afferent arteriolar pressure decreases. That causes secondary hyperaldosteronism. What does aldosterone cause? It causes sodium and water reabsorption. Following sodium and water reabsorption, what will happen to the urine? The urine will be a concentrated urine. Because of water reabsorption, the urine will be a concentrated urine with low sodium. Do you all understand this? Are you all with me? Hypoperfusion, yes. Listen to this, Mohanraj. I'm going to tell you about it. Yeah, so tell me what will happen. Urine will be concentrated with low sodium. When urine is concentrated, can you tell me what will happen to urinary urea? When urine is concentrated, urinary urea will be high. So if you take a ratio of urinary urea by serum urea, if it is more than 10, if urinary urea by serum urea is more than 10, that is most probably pre-renal form of acute kidney injury, telling you that the urine is concentrated by secondary hyperaldosteronism. Because there is sodium reabsorption, urinary sodium will be less, right? Urinary sodium will be less than 20 millimoles per liter. And fractional excretion of sodium will be less than 1%. So tell me, what is the criteria based on which you will differentiate pre-renal form of acute kidney injury from renal form of acute kidney injury? In pre-renal form, the urine is concentrated. So urinary urea by serum urea will be more than 10. Urinary sodium will be less than 20%, 20 milliequivalents per liter. Fractional excretion of sodium will be less than 1%. Is that clear? Now look at these values and tell me what is the right answer. Urinary urea by serum urea, 880 by 126. It is less than 10. Right? It is less than 10, which means urine is diluted. And you look at fractional excretion of sodium. Okay, we cannot calculate it now because they have not given urinary creatinine. So look at sodium values. Sodium values more than 20 millimoles per liter, which means there is salt wasting. If there is salt wasting, what will you suspect? Acute tubular necrosis. If it's acute tubular necrosis, then what form of acute kidney injury has it progressed to? It has progressed to renal form of acute kidney injury. Is that clear? Yeah. So now do you all understand that a conceptual understanding of biochemistry is essential for you to understand every clinical subject? Yes or no? Yes, biochemistry is not just about pathways. It's not just about cycles. There is so much beyond it. Yeah, only when you have a conceptual understanding of biochemistry, you will be able to understand all clinical subjects. Okay. So that's about this MCQ. What is the ABG abnormality here? Do you see any ABG value here? If at all it is present, it will be metabolic acidosis. If at all it is present, it will be metabolic acidosis. Okay, because bicarbonate reabsorption is affected. I will tell you in the next question. So this is the next question for you. A 56-year-old man, a known hypertensive, presented to his family doctor with loss of appetite, weight loss, generalized weakness and lethargy of 6 months duration. Blood sample was taken for analysis. So look at all these values and look at these choices and tell me what is the right answer. So start from looking at urea, creatinine, then look at all the other electrolyte values and then tell me the right answer. Is it choice A, B or C or D? Okay, I'll start telling you. Can I? NEET PG 2023. Very good, NEET PG 2023. Answer is B. Excellent. Manish, Deepthi, Narayan, very good. PTH value is expected to be high. Okay, so let me tell you all about, it is a case of chronic kidney disease. Very good. So let me help you understand these values. You look at urea is elevated. You look at creatinine, that is elevated. So you know it's a case of kidney disease. And they say that the history is for 6 months duration. The person is a known hypertensive. So most probably it is chronic kidney disease. And that is substantiated by the fact that potassium value is elevated. Yeah, 3.5 to 4.5, it is elevated. And what do you see about bicarbonate values? The normal bicarbonate concentration is 21 to 27 milliequivalents per liter. In this case, bicarbonate value is less. Look at phosphate value. Phosphate value is elevated. Right, phosphate value is elevated. So can you tell me the reason behind hyperkalemia? My question is, why do you find hyperkalemia? Why do you find low bicarbonate? Why do you find high phosphate in chronic kidney disease? High potassium is observed because kidney's function is to secrete potassium. Do you all know that? One of the functions of kidney is to secrete potassium. So when kidneys fail, potassium accumulate. That causes hyperkalemia. Why do you find low bicarbonate? Because one of the functions of kidney is to reclaim bicarbonate. If you are asked which is the major plasma buffer, what will be your answer? The major plasma buffer is bicarbonate. Okay, so can you allow your kidneys to filter all bicarbonate and allow it to get excreted in urine? No. So though glomerular filtrate will have all the bicarbonate of plasma, when this fluid goes through proximal convoluted tubule, PCT reclaims every bicarbonate into the circulation because your body needs bicarbonate as a buffer. So what is the function of kidney as far as acid-base balance is concerned? Kidneys help in reclaiming bicarbonate. So when kidneys fail, no bicarbonate reclamation, that causes metabolic acidosis. Is that clear, all of you? That causes metabolic acidosis. And then why do you find hyperphosphatemia? What is the reason behind hyperphosphatemia? There is a cell turnover that is always happening in your body, and whenever there is cell turnover, membrane phospholipids will give rise to phosphate, but you should not allow phosphate to accumulate. So kidneys filter the phosphate into urine. Do you understand this? Kidneys will filter the phosphate into urine. When kidneys fail, there is hyperphosphatemia. So what are the electrolyte abnormalities that you expect in a patient of chronic kidney disease? Hyperkalemia, hyperphosphatemia and low bicarbonate. Now what do you think will happen to calcium levels? Yes, carbonic anhydrase helps in reclaiming bicarbonate. You're right. So tell me, what do you think about calcium levels? Calcium level will be low. Why do you think calcium level is low? Hypocalcemia is because of low 125 dihydroxycholecalciferol. Do you know in the steps involved in vitamin D synthesis, 1-alpha hydroxylase is present in kidney. So whenever there is chronic kidney disease, kidneys do not only fail in filtering, kidneys also fail in their endocrine function. When 1-alpha hydroxylase activity is low, there is low 125 dihydroxycholecalciferol, and that is the reason for low calcium. So what is expected when there is hyperphosphatemia and hypocalcemia, all of you? When there is hyperphosphatemia and hypocalcemia, both these will stimulate parathyroid gland to release more parathormone. Because what is the function of parathormone? Parathormone helps in calcium reabsorption. and it helps in phosphate secretion. Yes or no? If you don't know it, please memorize it. What does parathormone do? It causes calcium reabsorption, it causes phosphate secretion. So whenever there is hyperphosphatemia and hypocalcemia, that will stimulate parathyroid gland, and that causes secondary hyperparathyroidism. What will happen whenever there is secondary hyperparathyroidism? That goes and attacks bones, and that causes bone resorption. And because of this excessive bone resorption, that can be renal osteodystrophy. So what is the reason for renal osteodystrophy with pathological fractures happening in chronic kidney disease? It is because of hyperphosphatemia and hypocalcemia causing secondary hyperparathyroidism, and the secondary hyperparathyroidism causes renal osteodystrophy and pathological fractures. And you will be able to identify that the person is proceeding to secondary hyperparathyroidism not only by estimating PTH values, because estimating PTH has got its own limitations. Yeah, it has got its own limitations both in terms of the cost and in terms of availability and in terms of interpretation of the reports. Because when kidneys fail, PTH accumulation does not only include bioactive PTH, that can be inactive PTH, which will give you a false high value. Okay. So instead of going and directly estimating PTH, what you can estimate is, you can estimate alkaline phosphatase level. When PTH acts on bone, it causes an elevation of alkaline phosphatase. So if you are a nephrologist and if you are treating a patient of chronic kidney disease, you should be watchful of the person developing secondary hyperparathyroidism and ending up in renal osteodystrophy. To avoid that, what will you do? Of course, you will estimate PTH, but frequently you can estimate alkaline phosphatase level. If that keeps getting elevated, that's a signal that is given to you that your patient is proceeding to secondary hyperparathyroidism. So how will you avoid the secondary hyperparathyroidism? By two ways. One is supplementing the individual with 125 dihydroxycholecalciferol. Okay, that will bring calcium levels to normal. That is one way. Another way is by giving calcimimetic drugs. I made biochemistry easy, and I'm happy that you're liking biochemistry now. So what was I telling you? To avoid secondary hyperparathyroidism, what will you prescribe to the patient? You can prescribe calcimimetic drug. So what are the calcimimetic drugs that you know of? Cinacalcet, right? Or ethyl-calcetide. You must have learnt all of this in medicine, right? Yeah, cinacalcet and ethyl-calcetide can be prescribed to avoid secondary hyperparathyroidism. How do they avoid secondary hyperparathyroidism? Because as the name indicates, they mimic calcium. And the major regulator for parathormone secretion, is calcium sensing receptor. What does this receptor do? It senses the serum calcium, and if it finds the serum calcium to be adequate, it inhibits parathormone secretion. Yes or no? It senses the serum calcium. It finds the serum calcium to be adequate. It suppresses parathormone secretion. Now, when you give a calcimimetic drug, this mimics calcium, goes and binds the calcium sensing receptor, and what will it do? It will cause an inhibition of parathormone secretion, so that will avoid secondary hyperparathyroidism. But what will happen when you treat the patient with excess cinacalcet or ethyl-calcetide? If you go and inhibit this parathormone too much, that can also end up in adynamic bone disease. When there is very low PTH, that can also end up in adynamic bone disease. That is also dangerous. And how will you know that the patient is progressing to adynamic bone disease? By estimating ALP. If a patient who has been presenting so long with a progressive increase in ALP is showing a decline in ALP below the normal levels, subnormal levels, that is an alarm. You should think of adynamic bone disease, and you should probably titrate the concentration of cinacalcet or ethyl-calcetide. So is that clear, all of you? Secondary versus primary hyperparathyroidism. I will tell you about it. So the difference between secondary and primary hyperparathyroidism is primary is always an intrinsic defect of the gland. For any reason, if parathyroid gland has started secreting more PTH, it can be because of parathyroid hyperplasia or it can be because of adenoma. So if there is a primary defect in the gland because of which excess parathormone is secreted, that is primary hyperparathyroidism. What is secondary hyperparathyroidism? The parathyroid gland is perfectly normal, but there is something else which is stimulating the gland to secrete PTH. What can be the stimulus for parathyroid gland? It is either hypocalcemia or hyperphosphatemia. It's either hypocalcemia, hyperphosphatemia. Example is chronic kidney disease causes secondary hyperparathyroidism. What is tertiary hyperparathyroidism? When there is long-standing stimulus for this parathyroid gland, there is a long-standing hypocalcemia, long-standing hyperphosphatemia. For a very long time, you have been stimulating, the patient's parathyroid gland has been stimulated. So at one point, the gland will undergo hyperplasia. Once it undergoes hyperplasia, it will start autonomously secreting the hormone. At this point, even if you treat the background cause, even if you treat hypocalcemia, even if you treat hyperphosphatemia, the gland will continue secreting the hormone. So the stage when it becomes autonomous, that is called as tertiary hyperparathyroidism. Is that clear? Yes. So now tell me the right answer. His 125 dihydroxycholecalciferol levels will be high. In a chronic kidney disease patient, do you think 125 dihydroxycholecalciferol will be high? No, it is going to be low. His PTH level is expected to be high. Yes, secondary hyperparathyroidism is probable, possible, because what you see here is there is hypocalcemia. 9 to 11 is the normal value. Here there is 7.2 and there is hyperphosphatemia. Hypocalcemia and hyperphosphatemia will cause secondary hyperparathyroidism. Okay, elevation of ALP indicates adynamic bone disease. Is that true? Elevation of ALP means there is secondary hyperparathyroidism. Decline in ALP means there is adynamic bone disease. Calcimimetic drugs should be avoided. In a patient who seems to have a propensity to develop secondary hyperparathyroidism, we recommend calcimimetic drugs. Okay, so the right answer is PTH level is expected to be high. Okay, I hope this session helped you all. Yeah, so I will meet you all again tomorrow. It is because kidneys are supposed to secrete all acids, Mohan Raj. So kidneys are supposed to secrete all metabolic acids in the DCT. So when kidneys fail, uric acid will accumulate. And there was one other question, right? I will tell you about that in the next class. There was some other question. Somebody was asking me to explain something else at the end of the session. What is it? PDF I will share. I will share it in the Telegram group. Okay? Okay, all. Thank you. Good night. See you all tomorrow at 7 p.m. Okay?